First of all, I would like to thank Dr. Hari for inviting me in this conference. That's my second time in India, and every year it's getting better and better. First, carcinoid tumors are often subject to dispute between thoracic surgeons and interventional pulmonologists. So how can we, interventional pulmonologists, give our opinion, and how can our interventions help patients with carcinoid tumors? First of all, neuroendocrine tumors, as you know, are a very variable group of tumors, ranging from diffuse idiopathic neuroendocrine cell hyperplasia up to neuroendocrine small cell carcinoma. But in majority of cases, you can divide them into typical, atypical by histology, but that is not the only thing that is interesting about carcinoids. Clinical manifestations can also range from none to endoluminal obstruction symptoms and signs, and diagnosis may be delayed as symptoms frequently mimic common respiratory diseases. Relapsing obstructive pneumonia with fever and chest pain, cough, hemoptysis, dyspnea, asthma-like manifestations, because these are in general very slow-growing tumors, and practically a lot of patients go unnoticed or asymptomatic, or they present with asthma-like symptoms. Asymptomatic lesions may be incidentally discovered by imaging procedures, which is above all CT, but CT is not really in all cases good for diagnosis of carcinoid tumors. Regarding other types of imaging, they are typically located in the large bronchi, most often in the right lung, and particularly in the middle lobe for some reasons. In about 30%, they have calcifications, isolated or diffuse calcifications, and in some cases, up to 40%, they can have peripheral position showing as round or oval homogeneous opacities. PET-CT, which we use to assess malignancy in other cases for carcinoids, is not really good, because it's due to low uptake of the fluorodeoxyglucose. So instead of that, gallium dotatate scan can show diagnostic accuracy more than 90%, and actually that scan can be used for non-invasive follow-up of patients after some intervention. Biopsy also has some considerations these tumors tend to bleed a lot. And if we do something during the biopsy, we can stop the bleeding or prevent it in some way. But really, in majority of cases, when you see that kind of intraluminal tumor, first urge is to recanalize the bronchus and not really to take the biopsy. And after all, patients, so the diagnostic procedure will be interventional at the same times. And one other thing, pathologists require a lot of tissue in diagnosis of carcinoids. So we usually put these two procedures into one. Endobronchial biopsy, some people use topical adrenaline to prevent bleeding, just pour it over the tumor. I prefer to use adrenaline via needle to inject it directly into the tumor. At the same time, you can take a core needle biopsy, or you can inject phenylephrine in the tumor and in some way prevent bleeding. EBUS-TBNA is another procedure that is mandatory in the case. Why? Because especially in cases of atypical carcinoid, you can never exclude lymph node involvement. Even on CT, lymph nodes cannot seem not to be enlarged. So the biopsy can be taken from these lymph nodes just to assess if are there any metastases or not. Radial probe is good, especially after the interventional pulmonology procedure, to assess the wall invasion. In this small study, actually, in 3 patients, while high-resolution CT only identified atelectasis, there was wall invasion. So we can use all the tools that we have to assess the lesion. What are the procedures for the therapy? For interventional pulmonology therapeutic procedures? Well, there are some factors we have to take into consideration. First, the tumor implantation, the base of the tumor, vascularization, the status of the airway beyond the tumor, localization of the tumor, and of course, the wall invasion. And in all cases, we have to practically mandatory to use combined approach. Combined approach means we can use rapid desobstruction techniques after for hemoptysis control, and to treat the rest or the base of the tumor. Mechanical recanalization is the number 1, but actually the best technique for resection is using loop or snare, prevents bleeding and removing the tumor at the same time. And with these procedures, we also have enough tissue for the diagnosis. Then the treatment of the rest or the base of the tumor, we can do either with argon plasma coagulation immediately to stop the bleeding, or with cryotherapy. In long term, cryotherapy can be of use. You will see later why. In this case, we decided that after all careful consideration to do mechanical debulking of the tumor with rigid scope. And just a small reminder, these are do's and don'ts in rigid bronchoscopy, in mechanical debulking. So, appropriate size of the bronchoscope to confirm the location and extent of the obstruction, to assess the diameter of the base of the tumor, to use appropriate anesthesia, to use gentle and controlled soft maneuvers when using instruments to avoid damaging the airway, and of course to monitor patients' vital signs. Don'ts, number 1 don't is do not attempt mechanical recanalization without proper training and experience in the procedure. If you and or your staff is not trained properly to do that, it's better not to do it. Remember, these are slow-growing tumors. Our major consideration here is post-obstructive pneumonia and hemoptysis. If you can control that, good. If you don't try to debulk it, either debulk it or not. Then we proceeded with simply by freezing the tumor. This is cryo-extraction and cryobiopsy practically at the same time. And we treated the base of the tumor with argon plasma coagulation. Post-procedure looks better. It was typical carcinoid without lymph node involvement, which was checked by EBUS TBNA, and right upper lobectomy was performed in this patient. Sometimes, in a lot of cases, you can, especially if you are doing it in a palliative setting to prevent recurrence of the tumor, you can treat it with cryotherapy. These are the major things we have to consider during cryotherapy, freeze-thaw cycles, but there is more to cryotherapy than just recanalization. Combining cryoablation with other cancer therapies actually may create a synergistic anti-cancer effect, greater than either monotherapy alone. Maybe it is not yet approved or tested on patients with carcinoid, but on other tumors it is. And another thing, it shows some immunomodulatory effect and potentiation also of combined immunotherapy and cryotherapy for malignant tumors. So there is more with cryotherapy than just recanalization, than just controlling intraluminal tumor growth. Complications, of course, you have to take care. In 5% of the patients, don't do excessive cooling, hemoptysis. There is always tumor necrosis, and you have to always take into consideration that tumors will bleed after cryotherapy, not during. They will tend to bleed after cryotherapy, and after the intervention, mandatory are follow-up bronchoscopies with removal of necrotic debris. Okay. That is technical part. What about evidence? How good it is IP treatment of carcinoids? So, first of all, is it with curative intent? Is it with palliative intent? And or bridging to surgery? There are several studies on the fact, and I will just shortly analyze two major studies comparing surgery and interventional pulmonology procedure, but not directly, you will see. But one thing we have to there is one thing we have to always think about during IP treatment of carcinoids. It's so-called iceberg tip effect. Tip of the iceberg, that means that visible intraluminal part might just be a tiny fraction of tumor growing from deeper inside the tracheobronchial wall. So I prefer not to be so in the technical part. I can do it. Long term, how it's going to help the patient. And this study is all about that, about long-term follow-up after first bronchoscopic therapy in patients with bronchial carcinoids. So it showed that actually intrabronchial therapy is justifiable with excellent long-term outcome, made surgery unnecessary in 42% of the cases. We are now speaking about 150 cases. And iceberg phenomenon and metastatic potential in that group of patients were clinically insignificant. Another study from actually there were 125 patients, and some predictors were analyzed. How good is actually, what are the independent predictors of the success of debulking? I mean intraluminal therapy. Intraluminal disease and tumor diameter on CT scan were shown to be independent predictors for successful endobronchial treatment, and actually patients with purely intraluminal carcinoid tumors with a diameter less than 20 millimeters on CT were good candidates for endobronchial treatment, regardless of histological grade, either typical or atypical carcinoids. So all patients in this study with a tumor diameter larger than 20 millimeters and or with nodal involvement or distant metastasis were referred directly to surgery. And successful treatment was defined as absence of residual disease during the first 2-year follow-up with CT and bronchoscopy after endobronchial therapy. Complications, bleeding, bronchospasm, and really minor complications of the therapy. So, in short, what are the predictors of successful endobronchial therapy with curative intent in carcinoids? First, it has to be typical. Second, with exclusively endoluminal growth less than 2 centimeters in diameter, bronchoscopically visible distant margin of the tumor as in any interventional procedures, without involvement of the submucosa or extension to the surrounding parenchyma, absence of lymph node involvement, base attachment less than 1.2 square centimeters, volume less than 5 milliliters, and no suspected distant metastasis. What about follow-up? These patients, regardless of histology, has to be very closely followed. After 6 weeks bronchoscopy and contrast CT and that gallium scan I already mentioned, if it was not available prior to diagnosis, contrast CT and bronchoscopy after 6 months, annual follow-up chromogranin, mandatory as a biomarker for this tumor, and 10-year total follow-up with contrast CT, bronchoscopy, chromogranin, biomarker testing. What about atypical carcinoids? Atypical carcinoid, regardless, first, all these studies were much more about typical than atypical carcinoids. Endobronchial resection in the first study I showed was curative in 17% of atypical carcinoid compared to 51. In short, the surgical resection combined with systematic nodal dissection for patients with atypical carcinoid is a standard of care, treatment based on the current evidence. So, but there are some biases, of course. In majority of studies, the local regional and distant recurrence rates were lower in endobronchial therapy-treated patients than in surgically treated patients. And this finding should be interpreted with caution because all patients with more extensive disease were automatically sent to surgery without endobronchial therapy, without interventional procedures. So, to surgery, typical carcinoid or a typical carcinoid larger than 20 millimeters, transbronchial invasion, metastatic disease, and unsuccessful endobronchial therapy. With palliative intent, much simpler. If endobronchial therapy cannot achieve radical management, it may offer, as we all know, two benefits to the patient. Patients who are not candidates for surgery, to remove bronchial obstructions, patients with hemoptysis, with dyspnea. And due to their slow growing, it may take even years before a recurrence develops. So, and the other thing, after the resection, the things are more clear in the airway. Like precise definition of tumor borders, we can use NBI, we can use autofluorescence bronchoscopy, radial or convex probebus to assess the wall and lymph node status. It's, of course, easier to do in the airway, which is not obstructed by the tumor. And this is in short, the proposed algorithm of treatment of carcinoids. If it's typical and has all these characteristics, can be treated and closely followed up. And if it's a typical carcinoid, more than 2 centimeters in diameter, and if we do a lymph node assessment and lymph nodes are involved, patient can be referred and has to be referred for surgery. But I am for this always. We should always try first, not try, do first interventional procedure whenever possible and whenever we assess that it has benefit for the patient. I would like to invite you all to the European Congress of Bronchology and Interventional Pulmonology, which will take place in Lisbon from 8th to 10th of May. And thank you for your attention.